Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important topic, cholesterol and lipid management. Why is this important? Because cholesterol, especially the bad cholesterol, low density lipoprotein, is basically responsible for the pathogenesis of atherosclerosis. And atherosclerosis is responsible for the two of the most common causes of death, namely myocardial infarction, heart attack, and cerebral infarction, brain attack. Since these two are the common causes of death, and atherosclerosis and the bad cholesterol or the low density lipoprotein cholesterol are responsible for this, we need to know and get to know all the concepts of these bad cholesterol, that is low density lipoproteins, good cholesterol, that is high density lipoproteins, and the 7 group of drugs which are involved in the management of lipid management and the management of atherosclerosis. So what is this bad cholesterol and what is this good cholesterol? Bad cholesterol is the low density lipoprotein. We can see here it is a core of proteins and fats. In low density lipoproteins, the fats are more, whereas in high density lipoprotein, the fat is less, the protein is more. So in low density lipoprotein, the fat content is more, and in high density lipoprotein, the fat content is less. Low density lipoproteins are bad cholesterol. They are primarily responsible for the pathogenesis of atherosclerosis, whereas high density lipoprotein is good. They are not involved in the pathogenesis of atherosclerosis. But why this bad cholesterol is so bad? Because this bad cholesterol, otherwise the low density lipoprotein cholesterol, transports fat from the liver to the blood. The bad cholesterol or the low density lipoprotein cholesterol transports fat from the liver to the blood. So when it transports to the blood vessels gets narrowed, forms atherosclerotic plaques, and can lead to thrombosis or embolism. Because fats, low density lipoproteins, are deposited in the blood vessel. So that's why they are known as bad cholesterol. Whereas the good cholesterol or the high density lipoprotein transports fat from the blood to the liver. So it takes away the fats, the cholesterol from the blood and the blood vessels to the liver, and therefore the blood vessels do not develop atherosclerosis. There is no atheroma formation, no plaque formation, no thrombosis, no embolisms. So in fact this is protective. So the more the high density lipoprotein, the more the good cholesterol, the better for the heart and the brain. The more the bad cholesterol, the more the low density lipoproteins, the bad it is for the heart, which causes myocardial infarction, and the brain, which causes ischemic stroke. So bad cholesterol, the low density lipoproteins, are bad because it takes fat from the liver and deposits in the vessels, blood vessels, and causes atherosclerosis. Whereas good cholesterol or high density lipoproteins are good because it takes fat from the blood vessels and puts back to the liver, and therefore the vessels do not form the plaques. So as I said, the bad cholesterol or low density lipoproteins are atherogenic. Once the endothelial cell gets injured, the low density lipoprotein gets into the tunica, and gets deposited there. LDL gets oxidized and forms atheromatous plaque, whereas HDL, it is protective. It takes away the fat from the vessels to the liver, and therefore it is anti-atherogenic. The polysaturated fats contain bad cholesterol or the low density lipoproteins, and therefore they are bad. We advise people to take unsaturated fats because unsaturated fats contain the high density lipoprotein or good cholesterol, and therefore they are anti-atherogenic. Smoking is one of the most easily modifiable risk factor for myocardial infarction or for stroke. One of the unhealthy habits which can be modified to protect from the development of the myocardial infarction or ischemic stroke. How does smoking cause arthrogenesis and the bad cholesterol, how they are responsible? When a person smokes, it goes and injures the endothelial cell. The endothelial cells line the blood vessel. So when a person smokes, it goes and injures the endothelial cell. It is the first point of the initiation of the pathogenesis of atherosclerosis. When the endothelial cells are injured, it gives away, and the low density lipoproteins which are present in the blood enters the vessel. And smoking also oxidizes the low density lipoprotein. So this oxidized LDL along with macrophages and platelets form a plaque and narrow the vessel, and therefore the blood does not flow in the vessels to the tissues. If the blood does not go to the heart, it causes myocardial infarction. If the blood does not go to the brain, it causes ischemic stroke. And therefore smoking is very bad and easily modifiable risk factor. If one factor that can be modified to prevent the myocardial infarction or stroke, an unhealthy habit which can be modified is smoking. So smoking is bad. It can cause atherosclerosis and increase the LDL levels. Exercise on the contrary is very good healthy habit. It decreases it causes a favorable lipid profile. It increases high density lipoproteins. As smoking oxidizes LDL and is injurious to health, the exercise on the contrary increases the HDL, high density lipoprotein, and protects the vessel from getting atherosclerosis because it increases the good cholesterol. Just 150 minutes of exercise per week of moderate intensity is sufficient to prevent atherosclerosis. 150 minutes of moderate exercise, that is brisk walking, in a week, that is 30 minutes every day for 5 days a week of brisk walking is sufficient to prevent from the development of atherosclerosis. So exercise is really beneficial in the prevention of atherosclerosis, and the American Heart Association has recommended 150 minutes of moderate exercise like brisk walking a week, that is 30 minutes per day for 5 days a week. So exercise causes a favorable lipid profile and prevents persons from developing heart attack or stroke. Alcohol is very peculiar risk factor because small amounts of alcohol is good for health, but then the persons will not stop with small amounts of alcohol and start to take increasing amounts of alcohol, which can be atherogenic. So it is actually a J-shaped curve. Small amounts of alcohol is good, but if we take lot amounts of alcohol, it's going to be bad for the health. Alcohol can cause obesity. The obesity, that is the accumulation of fat, can be of two types. One, around the abdomen, above the waist and around the abdomen, which is commonly seen in the males. A male pattern of abdominal obesity, what we call as an apple-shaped body. Women tend to accumulate fat on the thighs and the posterior, which we call as pear-shaped obesity. This apple-shaped obesity is more dangerous. When the fat accumulates around the abdomen, it is more dangerous than the fat getting accumulated on the posterior. Why? Because the fat in the abdomen has got is more lipophilic and can enter the portal veins, the portal circulation, and can directly go to the liver and can produce a disastrous metabolic profile. Because the abdominal fat can enter directly into the portal vein and to the liver, it can cause disastrous metabolic profile. So apple-shaped obesity is more dangerous than the pear-shaped obesity. Diabetes mellitus is also a risk factor. It increases LDL and can cause diabetic dyslipidemia. And therefore, I'll discuss the statins in detail, but statins basically decreases the LDL. Since it decreases the LDL and increases the HDL, it can prevent the thrombus formation, atheromatous plaque formation, and embolism. So statins we use, which I'll discuss in few minutes from now, very beneficial effects. But then the question comes, if the LDL, the bad cholesterol, is so bad for the health, why in the first place is it created? Why is it in the first place existing? Mother Nature probably has created low density lipoprotein for us to get on the situation of adverse circumstances like starvation. In starvation, where we need to survive, where we need energy, the LDL cholesterol comes and gives us energy. So in starvation, where we need to survive, that time the LDL is used because fat from the liver to the blood for energy. So fat moves from the blood to fat moves from the liver to the blood for energy. It gives rise to energy to the tissues. So to pass on the tough situation of starvation, the low density lipoprotein may be useful. That is only in starvation. But by and large, low density lipoprotein or the bad cholesterol is really bad for health because it deposits the lipids in the blood vessel, causing atheroma formation. Right. Now, it's becoming alarming when we talk about this bad cholesterol in terms of coronary artery disease, carotid artery disease, causing two major killer diseases of the world, heart attack, myocardial infarction, or the cerebral infarction in carotid artery disease. So how are we going to manage? What are the drugs which we can use efficiently and smartly to control this dyslipidemia? We have excellent 7 groups of drugs to control this dyslipidemia. And what are they? How do they act? Basically, the lipids are of 3 types. One, the cholesterol, which is used for synthesis of bile acids and steroid hormones. Then we have the triglycerides, glycerol and fatty acids, which are used as a stores for energy. Then we have phospholipids, which are the components of the cell wall membranes, and they are used for emulsification. So how are the drugs going to help us in managing this dyslipidemia? The first group of drugs, perhaps the most important group of drugs, is the statins, HNG-CoA reductase inhibitors, like atorvastatin. These are the number 1 drugs which are used in the control of dyslipidemia, that is, increase the HDL level and decrease the LDL level. But how does this act? In the liver, the acetyl-CoA gets converted to HNG-CoA. Then the HNG-CoA gets reduced through an enzyme known as HNG-CoA reductase to mavaconic acid. The mavaconic acid gets converted to cholesterol. And therefore, when we give statins, it inhibits the HNG-CoA reductase and therefore inhibits the conversion of HNG-CoA to mavaconic acid. Because mavaconic acid and upstream cholesterol are not formed, body tries to compensate. Body tries to compensate by drawing the LDL from the vessels back to the liver. And therefore the LDL level in the blood comes down. So because the cholesterol is not formed, body tries to compensate by bringing the LDL from the blood vessels back to the liver. from the blood and blood vessels back to the liver, and therefore the LDL level in the blood vessel and the blood comes down, and therefore person has got anti-thrombogenic effects. This is how the statins act. It is an HNG-CoA inhibitor reductase. But statins can produce a side effect of myopathy. It is speculated that the myopathy is because of the decrease of the mevalonic acid. So steroids are the most effective drug in the management of dyslipidemia, and one of the common side effects of statins are one of the most common drugs used in the management of dyslipidemia, and one of the common side effects of statins is myopathy. So it inhibits the HNG-CoA reductase. The second group of drugs, the niacin and the third groups of fibrates, they decrease the triglycerides basically. The niacin and the fibrates, they decrease the triglycerides levels. Here if we understand one step, we can understand the mechanism of action of niacin and fibrates. It acts basically to reduce triglycerides. We have triglycerides in the blood vessel. We have triglycerides in the adipose tissue. For triglycerides to be transported from the blood vessel to the adipose tissue, we need lipoprotein lipase. So when the lipoprotein lipase gets increased, the triglycerides move on from the blood vessel to the adipose tissue and becomes anti-atheromatous. Because now the triglycerides has moved from the blood vessel to the adipose tissue. Likewise, we have another hormone known as hormone sensitive lipase, which transports triglycerides from the adipose tissue to the blood vessels. So if we inhibit this hormone sensitive lipase, the triglycerides cannot be transported from the adipose tissue to the vessels, and therefore the vessels remain anti-atherogenic. So the drugs either should increase the lipoprotein lipase so that the triglycerides are transported from the blood vessels to the adipose tissue, or the drug should decrease hormone sensitive lipase so that the triglycerides remain in the adipose tissue and do not enter the vessels. Very interesting. So the niacin group of drugs act on hormone sensitive lipase, and therefore it decreases hormone sensitive lipase. Therefore it will not allow the triglycerides to be transported from the adipose tissue to the blood vessels. So since there are no triglycerides in the blood vessels, it is anti-atherogenic. Likewise, fibrates act on the lipoprotein lipase and increases its level so that the triglycerides are transported from the blood vessels to the adipose tissue. So there is no triglycerides in the vessel. It is also anti-atherogenic. So niacin acts on hormone sensitive lipase, decreasing its level. Fibrates acts on lipoprotein lipase, increasing the level. Both allow the triglycerides to remain in the adipose tissue and not in the vessels, and therefore both are anti-atherogenic. So this is the mechanism of action of niacin and fibrates. Niacin of course can cause flushing as side effect because of prostaglandins. Right. The next group of drugs are bile acid sequestrants and cholesterol absorption inhibitors. Bile acid sequestrants and cholesterol absorption inhibitors both act on the small intestine where they are absorbed. But bile acid sequestrants act on the distal part of the small intestine, and the cholesterol absorption inhibitors acts on the proximal part of the small intestine. The bile acid sequestrants act on the distal part of the small intestine and decreases the reabsorption of the bile acids. So when the bile acid reabsorption is decreased as a compensation, liver takes LDL, and therefore the LDL level decreases. So this is the action of bile acid resonance. Likewise, we have the cholesterol absorption inhibitors. Cholesterol absorption inhibitors act on the proximal part of the small intestine they decrease the absorption of the cholesterol. Therefore, now the liver takes LDL from the blood, and so the blood LDL decreases. Example, ezetimibe. After statins, the most commonly used drugs are the cholesterol absorption inhibitors, namely ezetimibe. We have another group of drugs known as Pcsk9 inhibitors. The Pcsk9 inhibitor acts on the low density lipoprotein receptor and inhibits it. So when we give Pcsk9 inhibitors, it inhibits Pcsk9, and therefore low density lipoproteins are now not inhibited. They are disinhibited. Low density lipoprotein receptors are more expressed on the liver, so it pulls on the low density lipoprotein from the blood back to the liver, and therefore it is anti-atherogenic. So Pcsk9 disinhibits LDL receptors, increases LDL receptors on the liver, pulls the LDL from the blood back to the liver, and therefore blood LDL level decreases. And finally, we have omega-3 fatty acids. We see this in fish oil. They decrease the free fatty acids transport to the liver, and then they decrease the triglyceride synthesizing enzymes. So this is how the drugs act in the management of dyslipidemia. The actions of statins and Pcsk9 inhibitors are similar. They increase the LDL receptors on the liver. The action of the niacin and fibrates are similar. They act so that the triglycerides remain in the adipose tissue, not going into the blood vessel. The action of the bile acid sequestrants and cholesterol absorption inhibitors are similar. This acts on the distal small intestine. This acts on proximal small intestine. They decrease the absorption, and therefore the liver takes LDL from the blood back to the liver, so that the blood LDL level decreases. So for the best group of drugs to initiate for the management of dyslipidemia is statins, followed by cholesterol absorption inhibitors like ezetimibe. But if the triglycerides alone are increased, like alcoholism, we prefer using fibrates or niacin. So we need to have a good knowledge of lipids, especially the bad cholesterol and good cholesterol, because the bad cholesterol, low density lipoproteins are atherogenic, causes atherosclerosis, narrowing of the blood vessel, plaque formation, thrombosis, embolism, does not allow the blood to go into the tissues, so the tissues die. If the myocardial tissue dies, it is myocardial infarction, the most common cause of death in the entire world. If the blood does not go to the brain, it causes stroke. It is also one of the most common cause of death. And therefore, since these are killer diseases, myocardial infarction and stroke, and since lipids, especially the bad cholesterol, is responsible for it, we need to know all the concepts of the bad cholesterol and how to control bad cholesterol, manage the dyslipidemia in an effective, smart way by using these 7 groups of drugs. I really enjoyed giving this lecture, and I hope you have also enjoyed listening to my lecture. If you have any doubts, suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.